Welcome back, everyone. I hope you all enjoyed your lunch, and hopefully you met someone you didn't know before. There will be more opportunities to network and meet even more people. Today, those of us in person have the opportunity to share insights on reimagining veterans healthcare. I'd also like to hear from our guest at home and ask, what does innovation mean to you? Take a moment to type in the chat your thoughts, comments, and answers to this question, and start some meaningful conversations with your online peers. Now, our next session centers on value and what it means in the world of veteran healthcare. As we reimagine veteran healthcare, we see that value chain for health innovation goes beyond dollars and cents. Healthcare innovations, digital health solutions, and emerging modern-day technologies offer improvements in the safety, effectiveness, equity of veteran care across the nation. So how do we build on this foundational value to support the Healthcare 2030 that we heard about before? To begin this conversation, I want to welcome to IEX Dr. Ryan Vega, Chief Officer of the Office of Healthcare Innovation and Learning.
Thank you, Eric. I'm going to start briefly, and then I'm going to ask a colleague of mine, Jen Goldsack, who's the CEO from the Dime Society, to come up, and we'll flip my remarks with hers so that we can go right into the panel. One thing I will touch upon very briefly is that the idea of value really is something that is a challenge in healthcare because we try to measure it as if it's a singular event, meaning that what may be valuable to you today is certainly not what may be valuable to you in a year or 5 years or 10 years. And so you're really chasing something that's really hard to measure. And because of that, it's also equally hard to define. One of the things that we've learned over the past couple of years as we've thought about meaningful innovation beyond just incremental innovation is the idea that value is dynamic and that it is something that exists across multiple stakeholders, patients, providers, and even the systems that care for them. The second principle that I think plays into upon how we really scale value is to become obsessed with human-centered design. Now, it's not to say that solutions shouldn't be patient-centric, but the idea that they obsess over patient centricity means that we ignore that there's usually somebody delivering that care, a nurse, a doctor, a surgeon, or an administrator. And so human-centered design must take into account all perspectives, not just the patient's. The third, which is equally important, is to understand that to really drive value, you must think about not only where to scale a solution, but when. When is a solution really ready to enter a new market? What impact is it going to have on that market? And we see this challenge with AI and digital therapeutics or digital health, and that just because it works for one population, just because it works in one hospital, does not guarantee it's going to work somewhere else. And yet we continue to make that mistake by assuming that, well, hey, this AI algorithm solved sepsis at hospital A, it's going to do the same at hospital B. And the reality is that even though the algorithm isn't changing, the way that medicine is practiced, the electronic medical records, the way that clinical care processes evolve from site to site are all real factors that change the dynamics of whether or not that solution is going to work. And the fourth key principle is that you have to develop an ecosystem. And this is really important. And I think something that we've really learned and valued is that you cannot do all of this alone. You have to be able to bring in partnerships. For us, this is private sector and industry and either other academic and government affiliates. If you're in the private sector, it may be working with government. But the ability to share those risks, the ability to leverage the talent and the both human and working capital that exist across actually allows us to get better solutions. And when you have more diverse opinions, when you have more diversity of thought and challenge, you get a better product. And that product is more likely going to deliver value to the end user than if you try to go at this alone. A couple of months ago, actually it feels like it was decades ago, Jen and I had the opportunity to present this work to HIMSS. And we presented our value-based framework and work that the VA and DIME have been doing to really think differently about the concept and the construct of value, thinking about value across multiple domains and across multiple stakeholders. And so I'll ask Jen to come and join me, and then we'll bring the panel up to just talk a little bit about the work that we're doing and to sort of go a little bit more deeply into this idea.
Fantastic. Thanks, Ryan. Good afternoon, everyone. Jen Goldsack, as Ryan said, CEO of the Digital Medicine Society, and I'm going to see if I can get some slides up here. For folks who don't know our organization, DIME, we are a global nonprofit dedicated to advancing the ethical, effective, equitable, and safe use of digital medicine to redefine healthcare and improve lives. And it's been an absolute pleasure and privilege to be able to collaborate with you and your extraordinary team over the last couple of years. And you seeded a little bit of the work that we've been doing, which we'll dive into both in these remarks now, which I promise to keep brief, and then in our conversation with this extraordinary panel. But to give you a little bit of backstory on who we are at DIME, I think the impact that we've been able to have on the field is the fact that we established ourselves to sit at the intersection of two communities. We don't sit in the clinical environment, and occasionally, often too late, when we already have an idea of what it is we want to do, pull in some innovators and say, you know, can you help? Nor do we sit in the technology side of the house and think about, you know, being the tail that wags the dog, you know, perhaps talking to a clinician now and again, and if you're really lucky, perhaps talking to a patient now and then, but, you know, we don't want to go too crazy. What really, I think, got it right for the impact that we've been able to have is this idea, just as you said, Ryan, that this is a collaborative endeavor. At DIME, we think about digital medicine as being the most interdisciplinary sort of field that you could imagine, from citizen scientists and cybersecurity experts through to the engineers and the physicists who are like making the chips, making the boards, through to product folks, data scientists, clinical care providers, healthcare executives, payers, regulators, funders, investors. Unless we are driving towards the same definition of value, we are not going to be successful in this endeavor. And unless we are breaking down those silos, for example, in cybersecurity, right? Security has been commoditized in almost every other industry. We don't need to build it from scratch. We have to do better. And that's what we do at DIME. And that's, I think, one of the principles that we've brought to our work together with our colleagues at VA. And through sort of community building, this very diverse community, through the execution of applied research and pretty extensive educational initiatives, we're trying to debunk the myth. And I think we've done this very well over the last few years, that you can either be glacially slow and call it rigorous, even though there's such enormous unmet need, or you can move fast and break things. We think about clinical quality work on a tech timeline, moving fast and fixing things. And that's, I think, the lens we bring to all of this. But our session today is about value. And I think that, you know, you can go to the literature, as indeed we did. We went through, you know, nearly 100 from the last sort of 30 years, peer-reviewed scientific publications about let's define value in healthcare. The goal here was not to say, we've got another one to add to the mix. The goal here was to say, what is it that we're doing here? What does good look like? There's a throwaway turn of phrase I like, which is, if you don't know where you're going, anywhere will get you there. And so the reason we put this together is to say, what is our North Star? What does good look like? And as we think about innovation and we think about determining value and we think about me being a digital health enthusiast, I'm going to give myself a pat on the back for not showing you a nice investment curve. Like we've never spent money on innovation before. First of all, it's tanked recently, so there's that part of it. But in the same vein, let's actually be serious for a second. I think, first of all, just because in a frothy market, people have been throwing money at things doesn't mean that it's high quality. That's not to say that we don't have to have a real talk conversation about the fact that there need to be incentives for people to innovate, right? Especially in industry. But at the same time, we mustn't mistake dollars and activity for value. And I think that's really, really important. And I want to talk about something else, because as we think about what is value, there's an example, and it's almost 100 years to the day, where a little 10-year-old boy in Toronto was starving to death due to type 1 diabetes. And he was the first human ever to be injected with insulin. And it saved his life, and insulin for the last 100 years has saved the lives of many, many individuals. Now, what's your return on investment? That's a lifetime administration of medication. What's value in that case? Was that a bad decision? And I think it's a particularly good example because the US is on a human rights watch list right now because of the cost of insulin. 1 in 4 Americans with diabetes ration their insulin because they have lack of access to something that was an innovation 100 years ago. So when we think about what value is, when we think about what meaningful innovation is, we have to think about not just raising the average by pushing up the top end. We have to think about bringing everyone with us. And one of our favorite things at Dime about working with our colleagues at VA is the way that you approach every single veteran and their community in your care. I think it is absolutely the right place for us to get this right when we think about innovation. And some of the other things, and I was looking at this slide earlier, and I want to say Drs. Vegas, Patel, and Clancy, and I, the non-doctor and the loser at the table, put this piece together in Health Affairs. And this is not to say, like, here are your 3 sort of silver bullets, and this is what good innovation looks like. But there's been some really interesting things that we've been working on, and Ryan, you mentioned some of these. So it's that relentless focus on human-centered design. And I like the fact it's human-centric as opposed to patient-centric. And you got to this, right? It's not because the patient isn't at the center of healthcare, but we're nothing if we don't have the people who are there to care for them, whether that's their individual support system at home, or whether that's the extraordinary members of the clinical community who have endured everything we've asked you to in the last few years, and you've stuck around. And with and there is a mass exodus right now. We need to do better. We need to keep that focus on human-centered design. One of the things we see VA doing that we don't see happening anywhere else, quite frankly, is building and maintaining that infrastructure. Whether it's training the staff and developing the in-house skills to position every single member of the care team for success, or whether it's the operational infrastructure to be able to hang innovation off. It's absolutely critical. And I think the other piece, and we have a lot of fun talking about this, right, is this idea of redefining the healthcare value chain. And again, VA does this better than anyone. And I want to show this, and unless you have binoculars, you're not going to be able to read it, but there's a source on the slide here. Yeah. And this is really important. I think particularly vis-a-vis digital, but you guys do so much more innovation beyond that, is we think a lot about individual widgets, individual point solutions. And that is not going to do anything other than add layers of complexity to a system that absolutely cannot tolerate any further. We have to think about innovation more holistically. We can't just shoehorn 50 apps with 47 different logins into some manufacturing sites unless we're thinking about fundamentally reimagining what it means to care for someone. And that comes back to this idea of reimagining the value chain. These technologies, innovation allows us in this day and age to think beyond the walls of the clinic, not to wait for someone to present at the clinic sick, right? So that from the top of the value chain all the way through to ensuring that every veteran has a healthy and thriving life and is able to engage in their activities of daily living without impediments to their health is absolutely fundamental. And as I said, I think you guys do this really very well indeed. And then this is what Ryan was alluding to. So when we came to, what's our North Star? What does good look like? And, a couple of things. Ryan, you gave this really lovely voice. This is not dogma. And this is not a checklist. This is a North Star. This is what are our values when we think about what good looks like and what are the questions that we need to ask. Ryan, you spoke about meaningfulness, appropriateness of scale, time to value realization, the whole thing as part of this thriving ecosystem. But I also think the value measures are really important, and I'll spend just a second here, because we spend a lot of time thinking about this. We have
Arguing.
to... Yeah? No, just spirited debate. I always feel I present very well because I sound like Mary Poppins, and even if I swear, it's fine.
I learned how effective a British accent can be in a spirited debate.
That's right. So anyway, what we agreed to with joy were these four categories. So access first and foremost, right? And this comes back to the idea that we want to make sure that every time we are thinking about improving the way we deliver care, we are promoting improved access, and we are that is a fundamental value. We think about effectiveness. The interesting one here, and this was perhaps some of our more spirited debates, was around this idea that you don't see cost, but what you do see is efficiency. And one of the things that we talk about a lot in the United States, I'm half American, by the way, is this idea that we spend nearly 20% of GDP on healthcare. Well, frankly, I'm really proud of that. I like living in a country where we can spend $1 in $5 on healthcare. What I don't like is that in return, we have maternal mortality rates that are the absolute worst in the developed world. What I don't like is that we have terrible inequity. What I don't like is the healthcare system itself is the third leading killer. I mean, this is not good ROI. This is not value. And so for us, we didn't want to look at cost as a raw number. We really thought about efficiency. And then, of course, equity, because if we aren't bringing everyone with us, we shouldn't be doing it. And that's absolute table stakes. So, it's a pleasure to work on this. I'm excited for a broader panel conversation to really dive into some of these pieces. As we said, this is more of sort of a philosophy. This is a guiding approach, but it helps us rally around this shared idea across all of these different stakeholders. And the theme of today has been collaboration. What does good look like? In our opinion, this is what it is. And then the last thing I just want to applaud you and the rest of the VA team on is we actually put out just a couple of months ago, it's not just that you guys do phenomenal work, that you work tirelessly to improve the care of veterans, but it's your willingness and commitment to sharing that. So for folks who may not have seen this sort of open access resource yet, our playbook on digital healthcare really goes through 8 of the new digital tools in the toolbox and demonstrates the very best of VA practice and lays it next to the best of industry practice. I think, for all of you who are here at VA, you should be incredibly proud of how you are driving that leading edge. And hopefully, this can be a resource that's incredibly valuable, both internally to the team and for the ecosystem more broadly. And as you said, that fourth sort of pillar is the ecosystem. So I'll stop and let you welcome everyone else to the stage.
Great. Well, you spend just a couple of minutes with Jen, and you can see why we love working with her and the Dime Society, that passion that they bring to the work, but also I think that fierce sense that we can be better really pushes each of us so that we never sort of get not just complacent, but we settle for okay. And I think that that's really important. I'm going to welcome the panel up because I know we had some other remarks, but I think we want to get to hearing from you all specifically. Diverse panel, and I'll let them introduce themselves, but I think something that's equally important too is having a veteran up here. And hearing from that patient, hearing from that provider, health system perspective, and what I think is going to be the most challenging, which is how do we measure this? So as we sort of go, and Jen and I have introduced ourselves, but why don't we take a moment to go down, and as you introduce yourself, if you don't mind, tell us, how do you define value in healthcare?
I'm Mike Borges. I define healthcare being a patient of the VA health system, and 16 surgeries in 11 years. It's a lot of surgeries, so I define it as, it's kind of tough for me because being in pain so much, I'm in lots of pain, and from that point of view, I like the fact that they using leading technology, and they're providing us with good healthcare services and medications. But I define it from that point of view itself, the medications, the technology, the innovation, you know, they're at the leading edge, which I appreciate.
So my name is Ron Dixon. I'm the CEO of CareHive. I'm a physician by training. And I think, actually, when I think about value and the definition, it's really about alleviating suffering. And alleviating suffering on behalf of all the different constituents, right? So you have the patient, the most important constituent, that, you know, if somebody's had multiple surgeries and is in chronic pain, you want solutions that are going to make it easier for she to access that healthcare system and to get that pain alleviated. For the provider who's managing that patient, you're going to require ease of access to the patient and ease of prescribing medications so that there are no impediments and needs for callbacks and this mountain of paperwork and administrative burden. And then for the system, you want a system that values both the patient and the provider perspective so that there's remuneration that is really, that makes sense, right? So it's not about, well, actually, you have to come in to have a visit so that we can get paid for this, so we can't do anything digitally to manage this. So I think if we think about the reason why we go into delivering care as medical assistants, as doctors, as nurses, we really have this core belief in alleviating suffering. And if we kind of bring that rubric to the value equation, then I think we can think differently about how we can best serve, you know, patients like Mike.
Good afternoon. My name is Pothik Chatterjee, Vice President of Innovation at LifeBridge Health. We're a provider system in the greater Baltimore area in Maryland. And thank you, Dr. Vega and Jen, for giving us the opportunity to talk about healthcare innovation and value. We also have an incubator program for digital health startups called 1501 Health, which is a payer and provider joint venture between LifeBridge Health and Blue Cross Blue Shield of Maryland. And that program, I think, really defines how I think about value in healthcare innovation. As we move from a fee-for-service model here in the United States towards more value-based care, it requires collaboration between systems to be more transparent, exchange data between the insurance side and the healthcare provider side, and bringing in the patient perspective as well. So it's really about collaboration, transparency, data exchange to create long-term healthcare benefits and outcomes for the patient.
So Jen, I'm going to start with you on this idea of the dynamic nature of value. And what I think is really interesting is you heard the secretary this morning, we've got to improve access. Mm-hmm. But when we think of access, most people think that means that I wait 5 days, I wait 10 days. They think of it as wait time. And I don't think there's anybody in this room who I said, listen, 10 days you can wait, you're going to see an okay provider, or 15 days you're going to see the best provider. Mm-hmm. All of us would say, I'm going to wait 15 days. But we don't think of access as being more dynamic than just being time-bound. And so that's true for all of value. So how do you think and wrestle with this idea that it is so dynamic, yet we try to solve it by saying, oh, it's cost over quality?
It's a really good question, and I think I'd maybe kick the tires on two examples. The first is I'm going to reach to oncology for a second. So if you look at NCI Centers of Excellence, right, they see a much higher acuity patient mix. Oftentimes they see people later in their cancer journey when it's more advanced. Yet their outcomes are substantially better than what you see at sort of freestanding independent oncology practices in rural areas, for example. Even though the acuity of their patients, their case mix says that that shouldn't be happening. So it's not just that you can access an oncologist. To your point, how do we use innovation in this example to translate the decision-making, the depth of knowledge, the experience, the access to world-class care that you can get at NCI Centers of Excellence, and make that accessible to everyone, right? That, I think, is at the heart of this. I think the other point is, we talk a lot about this idea of moving healthcare upstream and actually creating a healthcare system rather than a sick care system, which it sounds very bumper stickery, but I think this is actually what technology allows us to do. We've always talked about sort of, right patient, right treatment, right time, but how can we actually think about access to preventative treatments so that you aren't, is it 5 days or 10 days after symptoms onset? How about we stop you from getting symptoms in the first place? And so I think there are these variety of different ways we need to be thinking about access. And to your point, it can't be sort of monolithic, otherwise we're going to sell ourselves short. And what is it that we're trying to access? It's the very best care possible, equitable access.
Right. And as you move that care further upstream, the challenge becomes, how do you pay for that new paradigm? Which is a challenge. And from a commercial health system, you see this challenge far more abruptly than we do. So how do you all think of this notion of it being quite dynamic from the LifeBridge standpoint?
Yeah, it's a great question. The reason that we wanted to make sure that we included the payer when we developed this incubator program is because in my 8 years of experience in healthcare innovation, I saw so many entrepreneurs of startups come up with amazing innovations that our doctors and nurses got really excited about, but the entrepreneur had not really thought about how to translate that value into commercial revenue that can sustain the business. So when we started 1501 Health, it was really important that we had senior executives across Blue Cross Blue Shield of Maryland involved as advisors into the program so that they're coaching these entrepreneurs from the very start of the 12-month program and helping them understand what type of data do they need to collect in order to qualify for reimbursement down the road. What does a pilot with a major insurance company look like? And what role can the health system play in putting into place or implementing pilots that show outcomes with real-life patients in a safe manner? The benefit or luxury that we have in digital health is that it is safe to test new mobile apps for patient communication or artificial intelligence platforms for earlier detection of cancer or helping make our hospital operations more efficient. So it's really important that we coach these startups and help them understand how to get paid for the value that they're creating, because otherwise they're not going to survive and they're not going to grow and scale at a national level.
Right. And the work that you all did during the pandemic with Under Armour, I had not heard much about LifeBridge, and when I saw that, it was, to me, a testament of the health system's willingness to just move and change a complete value chain, because you had to out of necessity. And Ron, we'll get a little bit more in depth into how do you really measure this in a few minutes, but from your perspective, as you think of sort of the dynamic nature of the concept of value, how do you all wrap your head around this from your vantage point?
Yeah, well, so CareHive, we're really focused on leveraging data and data science to be predictive about who might need certain things. And we're very interested in, as an internist, interested in chronic disease and chronic disease prevention and prevention of progression. As you said before, a patient is not just a patient at a moment in time. They're a patient at a moment in time as their life goes on and their needs change. And you have COPD, you'll be fine, you'll have an exacerbation, you might need a hospitalization, which might lead to another complication. And the system has to be built so that it can manage you through that process, not at one moment in time. When I was an internist, I was always frustrated. When I practiced, I was always frustrated on my schedule sometimes because I would have conjunctivitis with pink eye, first visit, and then I'd have a blood pressure follow-up as a second visit. And then the third visit, I'd have CHF exacerbation, needing hospitalization. And what I wanted was not to see conjunctivitis in person, but maybe get a picture and send a prescription if it's simple conjunctivitis. Blood pressure check, that all could be managed asynchronously, right? So have a system that allows you to accept asynchronous data. You can get a lot more data, and then you can actually manage the blood pressure. Do you need a medication change? Do you not? And that's where, again, AI could help you. And then for that third patient, I actually want to spend more time with the third patient who might need a hospitalization for their congestive heart failure exacerbation. So imagine then that you can take a larger, forget about my one-day schedule, try to generalize that to a larger population, say of an insurer, right? So an insurer will have a patient database of 600,000, a million patients, all who might have varied degrees of chronic disease. So if you could leverage that information and then start to be predictive using modeling about who might need what, who's the sickest of the sick. So we have sick care programs for those patients. But then who's the rising risk group? And then how can you predict who's going to get worse and who might need an intervention in advance of a hospitalization? So that's where we at CareHive are really focused on that edge. And what we do is we focus on using asynchronous engagement at first to communicate with those patients and navigators to make sure that they engage. So I don't think you try to take some burden off providers by leveraging technology, leveraging navigators, and then that provides access to the patient.
Right.
Right. So that's really how I think we need to think more about value.
Yeah, and I love conceptually the idea that what you are in result doing is you're making the system more efficient. That's really what it comes down to. Because, and Mike, we'll get you to weigh in here, but if you don't need to drive 30 minutes and then spend another hour trying to find parking to go sit down and somebody say, yeah, oh, Mike, your blood pressure's elevated. Well, of course it is. I just spent an hour and a half trying to figure out a goddamn place to park. So for your perspective, how do we move the conversation so that we're understanding what's valuable to you, not today. Right. If I'm having a heart attack, what's valuable to me is fix my heart attack. But what's valuable to you in a month, and 2 months, and 3 months? And as someone who's had as many surgeries as you can, what do you want in 5 years? And how are we organizing our care models around what you want, what's valuable to you?
Right. Well, how I see that is they could look at my record. Just look at my record. See, I was here. Then I had surgery. Then this happened. You can see there's a line there. I can almost predict what's going to happen as far as my conditions down the road, and maybe get ahead of that, somehow. Also, maintaining the standards of care and the quality of the medications. If a budget cut comes along, then there goes my medication. I have to switch to another one, or the quality will go down in the medication. They have to be mindful of that. No, don't let regime change come along and some guy says, "Oh, we don't think that's important." You got to be very mindful of that.
Yeah. How often do you have providers asking you, "Hey, what's valuable to you? What are you looking for?"
Well, my main doctors do a good job with that. They really do, but they're limited.
Right.
They're limited themselves, It's kind of tough. But my doctor do ask, But being limited with the government system, it's kind of tough.
Yeah.
Budget cuts, regime changes, it's tough. It's
Yeah.
very tough.
I appreciate that. And Ron, coming back to you, maybe I should ask the question, should we try to measure value? But I think we all agree we need to. How do we? I mean, how do we move away from just the traditional HEDIS metrics or Ortrix metrics, these traditional quality metrics? How do we start to actually measure this?
Well, I think it's really important that we do need some sort of standard for outcomes, as you were saying, right? So we want your pain to be reduced, and we actually, from a quality perspective, if we're really managing Mike well, we're actually reaching out and to him prospectively and saying, so how are you feeling today? And then what can we do to make your pain better? And that type of a system, which currently doesn't exist, that generally requires both technology, right? And then a feedback loop. And again, if you're going to burden a provider practice with that, it's too much. What we need is some sort of AI. AI is just another word for, we used to call it kind of quality improvement initiatives that were leveraging data, and now we're saying that, okay, we have a machine that's going to help us say what's better for us, so we're calling it AI. It's not that complicated. It just helps say, okay, your blood pressure's stable. Next step is you don't need a medication. So that doesn't need to be managed by a doctor. We can have We use navigators, again, to be that interface between Mike and the provider so that the provider only needs to be there when we're making important medication decisions. And then lastly, when you're thinking about value, I always like to think, as an entrepreneur, we think about ROI, to say to the VA system, right? And it's a difficult thing to measure when you're thinking about chronic disease ROI in the short term. That doesn't actually make sense. What you need is a way to look longitudinally at what has value both for the patient and the system. And you can actually leverage large data sets to understand what has value because you can look back and see where outcomes have traveled over time with these patients. And then you could use those models to be, again, predictive about which group of patients is likely going to have a certain outcome. And that's what we do. We call it real-time ROI. It sounds gimmicky, but what it allows you to do is then use a model to say, monthly, how is a patient doing compared to how you would expect that patient to be doing? And that's the kind of value that I think we need to see in the system, as opposed to looking out 2 years and saying, oh, well, we're going to measure the value of this digital health intervention 2 years out, which no system wants to purchase anything that's going to be measured 2 years out for an ROI.
Right. And to your point, part of the paradigm shift is an appreciation that healthcare is resource constrained. The supply is always going to be more limited than the demand. And so value is not just on that individualistic or translational. It's collectively, how do we take finite resources and apply them to the most vulnerable populations today, get them to be healthy and productive? And Jen, I'd love for you to jump in here. So as you hear these sort of notions, so how do we do a better job of bringing technology and digital solutions into these care models instead of these sort of point solutions, dump a ton of money in, hope that things stick?
Yeah, and it's exactly the right question, right? How do we actually think about retooling, re-engineering what healthcare is, as opposed to sort of shoehorning these point solutions in? And I think it really does come back to this idea that we have to be prepared, right? Given that our core business as an industry is ostensibly to care for people, that is a lifetime commitment. And I think that's why working with VA for us is so exciting, because in the private insurance market, people are turning over in their insurance every 2.3 years, I think it is right now, is the average time on a plan. There's absolutely no incentive to care at all about what's happening in 2 years and 4 months, because you're just saving money for someone else. And the reality is, and you've got some great examples of this. I think about, it's not technical at all, but like Pride, for example, right? Where you make care more accessible to members of the LGBTQ community. That means that today you are caring for more people than you were yesterday because you have a program. But what does that mean? Over their lifetime, they are going to be in better health. Mm-hmm. You're going to get ahead of any issues that could be catastrophic to their health and expensive. And so I do think we've got to stop looking at these slices of time. And as we do that, we think about how are we using platforms and systems to fundamentally reimagine how we care for people, and how are we thinking about that play and that end goal instead of, are there 13 apps we can shove into this workflow? Because, surprise, the answer is no.
They don't work. And Pothik, from the commercial side, but also your vantage point of seeing these incubation, the entrepreneurial spirit in these startups, cost is always going to be a part of the equation. It's inescapable. If you don't make money, you don't exist. So how do you encourage and really move the conversation so that cost is a component, but we don't so obsess over it that we lose sight of the opportunity? But then equally, how do you bring a lens of equity into this? Because you may have a solution that, if you can afford it, works great. But what about for those that can't?
Yeah, that's a really great question that we grapple with every day in our innovation department at LifeBridge Health. And we also have to answer to our finance department, to our CFO, to justify the capital that we're investing in these startups, the operating dollars that we use to fund 6-month to year-long pilots to show the impact on our patients and our providers. So I try to show that it really is a variety of factors that show the ROI from our investments. Partly it could be from savings, from efficiency, because we're using automation and predictive analytics to do really repetitive manual tasks that healthcare administrators would do in the past that can be done faster and more efficiently with computers and with technology. It could be new revenue streams through remote patient monitoring and some of these new codes that are getting approved for telemedicine and hybrid approaches to care. But I also emphasize the experience factor. If we're able to have a better experience for our patients and address the vulnerable populations in our community, that is really important to us as a nonprofit health system because it aligns directly with our mission to provide for all of the patients in our diverse communities in Baltimore. So I try to present it as a variety of factors. And to give you one or two real-life examples, one company that we've worked with is called Baby Life Advice. They're a virtual platform for maternal care. And as Jen mentioned, the United States is already lagging behind the rest of the world in maternal outcomes. But for Black mothers, the outcomes are 4 times as worse as it is for white mothers. And I'm really proud of the fact that our pilot program with Baby Life Advice at Sinai Hospital, which is the largest hospital in our health system, has over 90% Black mothers in the program that are getting free education around lactation coaching, around new motherhood and new parenthood. And that's something that we're currently funding through philanthropic dollars. But to your point, we need to figure out with our health systems, with our payers, with government and city organizations, how to make this sustainable, because we learned from the last 2 or 3 years with the pandemic that it didn't affect us all equally. If you came from a minority background, if you're part of the LGBTQ population, then you are having a different experience with access to care and with quality measures as well and outcomes as well. Another example that I want to share that came from a veteran innovator is a startup called Even Health, and they're focusing on mental health and wellness. And this came directly from the veteran space from an entrepreneur named David Black in Annapolis, Maryland. And he was trying to figure out how to address the PTSD issues and the mental health challenges and suicide ideation that a lot of veterans face. And while he was building the solution, which is a virtual platform for anonymous group therapy led by a licensed mental health facilitator, he realized that there's another market here because of all the nurses and doctors dealing with COVID and the pandemic burnout. He came to LifeBridge Health and 1501 Health and said, would you all be interested in using Even Health solution, which is called Cabana, for your employees? So we have been offering this for free to all of our employees. We have 13,000 employees at LifeBridge Health since the start of the year, and getting incredible feedback from our ICU and ED nurses about the ability to have a safe space that is anonymous, because there's still a stigma in the healthcare provider community as well about admitting that you need mental health support, that you need therapy, that you need some type of community. And companies like Even Health are really breaking down that stigma. And I'm so grateful to the veteran community for coming to healthcare and bringing us those type of creative solutions.
Yeah, it's a great point. And as we sort of get, and the time is flying, Mike, quickly, and then we'll go to some rapid fire. What are some of the solutions that, from your vantage point, from the patient's vantage point, are most important for us to prioritize?
Well, stuff like when they do come up with innovative systems, there's a lot of us older vets, the pre-computer, the pre-cell phone guys, the dinosaurs, okay, you could say the dinosaurs, that we're not up on technology.
Right.
And we don't want to have nothing to do with it. I had a flip phone before I had to get a smartphone for my job. I was fine. I say hi and bye, everything's good. But I'm a dinosaur. And providing advisors that can help the vets, they just give them a cell phone. They'll throw them a smartphone and go at it. What do I gotta do with this thing, But technology advanced so much now. And a lot of older vets are afraid of the technology, to tell you the truth. And they don't want to admit it, So give us a little technical support, That's all.
It's the pragmatic and the practical that's often the most important. Yeah. So some rapid fire.
Yes, sir.
So Jen, what's an area you think we've got to do a much better job at creating value? And what's an area you think healthcare is actually doing quite well?
I can answer the two questions with the same answer. Mental health. I think that you guys in particular are doing outstanding things with mental health. It is such an enormous area of unmet need. 1 in 2 counties in the US don't have any behavioral health care facilities at all. The idea of doing the traditional in-person approach is simply not going to work. We don't have the infrastructure for it. So, I think that that's the area of enormous unmet need. I mean, unfortunately, there are many, but I think from the values that we hold dear, that North Star, from access, from equity, efficiency, effectiveness, I think we can really go there for mental health. It's an absolute imperative. And I actually think you guys have been leading the way on that and have fantastic data to support that when we do it right and when we're thoughtful and when we prioritize these values, we can actually be enormously successful. Yeah. So that would be my take.
So Mike, we're going to let you close. Ron, if you could have a magic wand and solve data interoperability and compatibility today, what do you see as the most important data sets that are continuously missing in our healthcare experience that are absolutely vital for us to advance value?
Well, so there are integrated data sets that leverage a patient journey like an electronic medical record and patient claims information. And I think a lot of the themes, like what Paulik was talking about, like this theme of precision, I think that is what would make me the happiest. The idea of understanding who the system writ large needs to focus on, and then having the intervention to actually make that a priority. And not all patients, I like to say it's not a peanut butter approach, right? So some people need absolutely no intervention, like my kid right now, my son, he's healthy, doesn't need, but my mother, who has a bunch of chronic diseases, needs a lot, and she's not techie. So that means she needs somebody calling her, she needs somebody at the house. Then there's all these people in between. And you could leverage data to be predictive about even what the intervention that they're going to be most likely to respond to. So I think, to me, that would be the magic wand.
Paulik, from your vantage point, what are the things that excite you the most? And what are the things that you think are going to be the biggest challenges that we're going to need to innovate around?
I'm going to answer with the same theme. The biggest, most exciting opportunity is the trend of healthcare moving out of the hospital into the home. There's a lot of care that is currently provided in a hospital setting that is high cost, inefficient, does not need to be provided there. And using new technology and remote patient monitoring tools, we can actually work towards moving that into the home for the convenience of the patient. So I think that's a tremendous opportunity. At the same time, it's a challenge as well, because we have to now train our clinicians to adapt to a new form of medical care and monitoring. And it's not just the clinicians, there's a whole administrative infrastructure that goes behind it as well. So we set up something called a virtual hospital about 7-8 years ago. It's now called our digital care center. So we have been building that infrastructure at LifeBridge Health, but I think there's going to be a lot of challenges around developing that further.
Yeah. And Mike, for you, if there's one thing you could change, we made you, the emperor for the day. One thing you could change about healthcare, what would you change?
The decision making, the people who are making the decisions, I think that'll change. That'll be the biggest thing I do. And, they make some pretty cold decisions, may I say. And you balance life and the pursuit of happiness with the budget. It's kind of tough.
Yeah. That's good. So I think we're at the point where we can go to audience questions. Hopefully some folks have questions. If not, I'll generate our own.
I will awkwardly look at the camera, yes. Hi. That's what I was told to do. Hi, Caitlin Thompson from Red Duke Strategies. There's the camera. I am so grateful for this panel. I have had a lot of aha moments. Dr. Dixon, the one that I had with you was when you spoke about, the 3 patients that you have throughout the day and the conjunctivitis and then blah, blah, and how you would be able to manage and really care for those more difficult circumstances. So thank you. That really encapsulated a lot for me. And I am so grateful that you have Mike on the panel because and that you're using the word value for the value of the healthcare, but you're also saying it's the value of the veteran. Yes. And we value you. And so I was so glad when you said, as a dinosaur, we could have, like Dr. Dixon said, we could have something where you have conjunctivitis, you take a photo. Sorry, I'm not looking at you take a photo. Is that okay with you? And how do you, I think so much of this is going to be also around communication to the veteran of, listen, we value you, and we are here to help you in the best way that we can. So in order to do this, here's the technology. We're going to walk you step by step through this. And, but this, and because that is what is most meaningful for us. And I think that's going to be a huge challenge, but one that we need to take on. As I was listening to this, I was picturing all the country doctors back 200 years ago who made home visits. Boy, have we changed. And so how do we communicate that and make it so that as the veteran and the patient, that is as seamless and easy as possible? Thanks.
Thank you.
Ron, any thoughts? How we better integrate these care models wrapped around these new technologies?
Yeah, I think the scale question. So
Yep.
Obviously, everything requires a start, and starts means that terrible P word, which is called a pilot. I'm not a fan of pilots, but you do need somewhere to start. But you start with the thought towards scale. So you build infrastructure, technical infrastructure that you can scale on. You don't build something that then you'd have to break and rebuild. And then you're always looking to people like Mike and to providers to get feedback and iterate as you're building.
I'm Ritvik Agarwal. I'm one of the physicians and researchers at the VA, and thank you for this great panel and insight. Excuse me. I do research in data science, and we have this enormous data set with the VA system, goes back to 20 years. And we actually recently found some really interesting signals in sleep apnea, heart attack, and so forth. But one of the things which we were thinking, if we have the access to data across the entire United States, commercial insurances, Medicare, Medicaid, we could really see if the data applies to outside the VA system. And I think one of the speakers said that we are, like different logins, and how do we connect different systems? I think all you have touched on that. But what's the main barrier we are dealing with? Is it regulatory? Is it the insight? Is it the avail? What are the challenges here?
I can take a crack at this, and I'm curious to hear what others think. It's a really good question, and it's a really important question. What I'll say is there's absolutely no limitations with the technology. We could do that today if we wanted to, right? We are not going to tech our way out of this problem. It, I think, comes down to important conversations like this around what does good look like, what is value, right? What is that future state, and building intentionally towards it. And it's doing that, and this is up there with Pilot, Ron, that change management, in order to allow people to see that the goal of this is not to make your job harder. The goal of this is not to depersonalize care. The goal of this is actually to allow you to follow your vocation as a care provider and to care for people in the best way possible, and to earn that trust when we make that case. I can't tell you how many innovators I speak to on a daily basis, and they're like, oh, it's only 30 seconds per patient for the doctor. Are you out of your mind? out of your mind. That is absolutely unacceptable. So I think, do the platforms exist? Could we start doing, here's the throwaway term for you, like plug and chug today? Yes, of course we could. But what we actually need to do is take all of these individual sort of homegrown systems, and we need to partner, back to this sort of theme of collaboration, we need to start moving towards this future state. But first of all, we have to get everyone to buy into that we want this future state. And I think that's honestly where we are right now.
So for,
Yeah, no, yeah.
Oh, yeah. From our perspective, so we actually leverage large data sets to impact a population, and we actually look at the different data set. So we would look at a VA data set, for example, differently than we look at a commercial data set, because we build models based off of the larger commercial or veterans data set, and then that would allow us to predict what might actually, in the sleep apnea perspective, who might need to be prioritized. So I do think that you need to build large models around disease states, but then you actually need to plug in data from the specific populations to make them accurate.
Both think on the commercial side, I suspect it's the same challenges we have: privacy, privacy, and privacy.
Yeah, it's definitely an issue about privacy, and I would also say it's an issue about incentives, right?
Yep.
What insights is the data going to uncover that would move the needle on clinical outcomes and then help reduce the costs to incentivize that reimbursement? So it's a little bit of a chicken or egg issue. I will say one thing that gives me hope is that it's not a tech issue, because we do have some good models in place with the regional HIEs, Health Information Exchanges. Where I come from in Maryland, we have something called CRISP, the Chesapeake Regional Health Information Exchange, that allows us to see how patients are moving through our state, even outside of our hospitals, so we can understand the impact of new pilots, which I know is not a much favored term, but it helps us understand the impact on reducing readmissions to the ED, how we can avoid that with the use of digital tools. So maybe there's a model there that can inspire national data exchange with the VA.
And Mike, as a veteran, I've seen you all as a community want us to use your data to help make you healthier and your brothers and sisters healthier.
Oh, yes.
And there's encouragement from the patient side. It's just don't abuse it.
Right, and that's the problem, the abuse of it. One abuse kills it for everything.
Yep.
And that's the problem. But we definitely want it, anything that makes it better.
I think we had one more. Are we out of time? Can we do one more? Go for it. We can do one more. I can call an audible.
Hi, I'm Jackie Pickell. I'm an OBGYN, whole health chief in Tampa. And my question is this about our clinicians who are expected to adopt these new technologies. Love the point about that. But where are we as far as even introducing the topic? Because as we're discussing these new technologies, and we want our veterans, I'm a veteran too, receive my health care at the VA. I want this for myself, I want it for my brothers and sisters, but I also want my burned out colleagues to make certain that we are healing that team and then expecting to move the ball forward as far as the technologies. Because the patients experience the burnout firsthand.
Yep.
Right.
Yeah.
Right.
I'll comment as a provider. My notional feedback to people is, particularly in the VA, when they bring us solutions and they say, yeah, and it only takes 30 minutes to train, I say goodbye. If we're developing solutions that providers need to spend even 5 minutes learning how to use, we have failed. So that's why it's about human-centered design, not necessarily patient centricity, but if we aren't designing systems or solutions or products that make it easier to provide care and make the experience, in our case for the veteran or the patient, better, what are we doing? You don't use Amazon because it's hard to use. It's convenient, it's easy to use, it's reliable, and it works. Period.
Yeah, and the only thing I'd add is that we have to think about it as subtractive, right? So there can be no addition to the provider work. So if you're going to come in with an intervention or an innovation, it has to take time off, as you were saying. Otherwise, it's a non-starter.
think we're done. Is that the cue? I see Eric waiting in the wings to push me off stage. So, all right. Well, listen. Thank you all very much.